Well, let's get started. So we have heard a lot about AI and the science behind it, the care transformation it can lead to. However, we now are going to hear from people who are actually trying to create the use cases in health systems around AI and what challenges, barriers, and productivity gains they are seeing in real world. So this is sort of the culmination of this entire summit. We have done a lot of conceptualization. We have done a lot of what we need from federal level, state level, legislature. But what are we actually trying to do, boots on ground, is what we're going to hear from our panelists. So I'm very delighted to introduce our panelists. Emily Blomberg, she is the CEO and president of Regents Hospital right here. It's a level 1 trauma center, part of the Health Partners family. Emily is a former COO at the University of Iowa Health Systems, and prior to that, she was at Hennepin Healthcare. I have worked with Emily, and what I'm very impressed with is she's one of those rare operational leaders who understands the tech side of things. So I'm delighted to have Emily here. We have Dr. Jared Pello, who is the CMIO at Microsoft. But beyond that, his list of accomplishments are numerous, including being a serial entrepreneur. He's also an emergency medicine doctor. Dr. Ryan Jelinek is the Chief Health Information Officer at Hennepin Healthcare right here in Minnesota. He is an accomplished informaticist, has published on his informatics work, and is also an educator for the Clinical Informatics Fellowship. That's a joint fellowship between the University of Minnesota and Hennepin Healthcare. And Dr. Atreja, you already heard from. I don't need to repeat his intro. Accomplished gastroenterologist, entrepreneur, informaticist, and a digital innovator. So with that, let's get started. My first question for you, Emily, is, as a hospital president, what are you struggling with, or what have you accomplished in terms of AI solutions implemented around resource utilization, as an example? And it could be staffing, equipment, bed management. And then what impacts have you seen thus far? And it could be from your current experience or even your prior experience.
Can everyone hear me? Okay, I am on. Thank you. Thanks for the nice introduction, Deepti. It's really nice to be here with all of you. I've learned a lot in the past 2 days. So we've done a number of things at the organizations that I've been at, but as I was thinking about this, just some of the most impactful, I'll just call out a couple. One that we used at my prior organization and have just started piloting at Health Partners in the outpatient setting is ambient listening. And this has been like widely popular from all of our providers, and really on the side of time, which is creates more efficiency for their time, and also enhances the human-to-human interaction with patients. The other one that I would say has been hugely impactful at a previous organization is in the operating room, which, as you all know, is our most expensive location of care in a hospital. And using a software tool that interacts with Epic but is not a part of Epic, our electronic medical record there, that helps with resource allocation, both in determining block time for surgeons and making block time widely and quickly available when there is what we call white space in the schedule, but also, most importantly, assuring that block time has all of the resources as far as equipment, supplies, and nursing expertise that are needed for the case that needs to be done. And that's probably been one of the most impactful.
That's a great example. Follow-up question to that. When you think of AI driving operational efficiency, how do you define operational efficiency when you're running a large hospital system?
So that's a huge category of things that almost anything could fall into operational efficiency. What it means to me, so operational efficiency is using all of your resources, time, money, human capital, technology, in the most efficient way. The most important piece of that is to drive value, and the most important piece of value, in my opinion, is quality. So any of these tools that we've been talking about the last couple days and any efficiency that we produce from these tools means nothing if we are compromising quality at the end of the day for patients.
Thank you. My question for you, Dr. Jelinek, is As in your day-to-day role as a CHIO, how is your organization using AI to optimize resource allocation, and how do you measure success around the AI optimized resources?
Oh, there we go. Thank you, Deepti, for inviting me to this panel. It's been great to connect with the panelists and really engage with a lot of you on a really interesting set of topics. So in terms of resource allocation from a CHIO perspective at a safety net system, so Hennepin Healthcare, for those of you who are not local, across the river, level 1 trauma center, but it is Minnesota's designated safety net healthcare system. And so resource utilization at a safety net system is really paramount, right? We are all operating on very thin margins at all of our healthcare systems. And so when we incorporate AI into what we do operationally, it really needs to meet that rigor of a return on investment. We've talked a lot about how expensive these models are, not just to purchase from vendors, but then to implement and operationalize. That piece is where it really gets expensive, right? You need to vet these tools. You need to build the processes that will support the tools to actually do something. Otherwise, it just becomes another data point. And so one of the places that we started with is really at the beginning of the stack here in terms of our IT governance and product fulfillment. What we found is that from within informatics and IT, we were getting lots of requests from the organization. And they come in through a ticket via ServiceNow, like many of you have experienced. But what we find is that the information in that ticket was never enough. And so then we were using our own resources to go out and try to extrapolate the right information from operational and clinical leaders. And that would happen after the project starts. And so we're wasting a lot of time or wasting a lot of resources. So what we did is we took an on-prem LLM and we started to have this be part of the idea ticket submission process. And what we found is that it was actually really good at this. We would take information that the operational owner would submit through a form, and they would say, well, this is what I want. Here's a PowerPoint deck we came up with. And then the LLM would return a business requirements document that would really be structured so that our IT teams could take that and turn those into technical requirements. Then we could go off and run with the project. The idea behind this was to really drive engagement with our operational and clinical leaders to make sure we absolutely knew what they were looking for with the products that they were looking to deliver. And I think in starting this process, there's a really good cautionary tale of using AI for this sort of work. And that what we found is that people said, oh, well, AI will just do it for me. So they put in the bare minimum. AI spit something out that looks beautiful. And then we would get to a handshake process with the business owner. And it was clear that they really didn't ever review the AI output, right? And so we've talked about this theme over and over again, whether it's clinical practice, operational practice, is that if you're not engaging with the outputs of AI, you're kind of missing the point, right? You want to use AI as scaffolding, not the finished product. And so what we did to combat this was we said within that AI output, we asked the LLM to return a set of non-technical questions that the operational stakeholder had to answer. And so it kind of forced them into using the output in a way that was driving this engagement. And I think that's a really transformative way in how we think about using the output from large language models from an operational efficiency standpoint. So it's been interesting. We're about 3 months into this process, and so it'll be interesting to see how that drives our ability to deliver on time and on budget.
That's an awesome idea. I'm going to shamelessly steal that, actually. Question for you, Ashish, is as healthcare systems, and you're part of a very large system, cost is a big barrier right now. I mean, we are operating on 1-2% margins in majority of the healthcare systems. How have you successfully used AI to reduce operational costs while still maintaining that high quality Emily was talking about, or operational efficiency or patient outcomes? How have you successfully implemented an AI solution to drive down cost?
when we started this, our vision for innovation included IT to innovation technology. And the bigger vision was if a startup can create a new technology and can become a unicorn in 5 years. We had 600, 700 IT professionals. Can we take a segment of that and actually do exponential value creation? So I think the lens we started putting from a strategy perspective was, is it time for IT to transform itself to go from a cost to revenue generation center? And from that aspect, what we started measuring every single project with ServiceNow as we integrate, we started looking at ROI, but we also started looking at return on health, the AMA framework. Did it really impact patient outcomes, clinician experience, patient experience lower? Measurement capability became more than just a financial lens. So we could look at all of that, and we talked with CFO on that perspective and implementation gap. So a few examples which I'll give which really hit home is one is in the strategic roadmap we had identified access gap, big time. One of the things we found was we actually had many more, and it's featured in Epic, but it's not clear. When a patient cancels the appointment, cancels too late, the no-show rate is not accurate. So we had to manually calculate because we had discrepancy. And we found we were actually having a lot of no-show rate across the enterprise. We had initiated a project called as UC Now, which was just a text-based program, which will send out, this is before Epic came with its version, which will automatically remind every single patient about the appointment reminder, but it was a two-way message to the patient, and we did a phased approach. We first reminded, then we made every patient to confirm they're coming or not with a pressing 1. And if they did not confirm, it will automatically have a call that will go to them. Just by using that process, the cost itself was less than $5,000 a month for reminding everyone. It's 14,000 patients. We were getting it every single day. But we had got so many, like even with 2 radiology missed MRI appointments, which we fulfilled, or 1 colonoscopy, 2 colonoscopy, we fulfilled the cost for the entire program, right? And now because this was a platform which we had, we could build experiences on top of it. So we could automatically have, for MRIs, for example, do you have metallic screening? Patient could automatically. So I think we now have around 30, 40 programs which are built on top of it.
Excuse me, we're having interference with that lapel microphone. Could you just use a handheld microphone for the rest of the panel, please? Thank you. Sorry about that.
That's okay. I'm nearly done, actually, and I have taken a lot of time in speaking before, so I'll be very brief now. So I think simple things like appointment reminders, but keeping an eye on that and having a feedback loop for if they don't reply, we are able to get to the next person who calls in, helped us save millions of dollars.
Great example. I'll move to you, Jared. Being part of a large organization like Microsoft, all healthcare systems are trying to implement AI tools, but they are cost prohibitive, and it adds up. So how is Microsoft thinking about, helping organizations drive down the cost of digital health tools?
So I would say primarily, what Microsoft wants to do is have you use all their tools, and they'll give you better prices. But also, we've talked a lot about ambient listening, which over the last year, there's been 3 or 4 academic papers that have come out about ROI of ambient listening. And when you look at those papers, you're mostly going to think there is no ROI from ambient listening. Interestingly, though, they're all fairly short term. I think the longest was about 6 months. And having kind of been on this ambient journey for the last decade, we have partners like WellSpan Health, which is in Pennsylvania, that have been on ambient listening for many years now. And what we find is that after a year, generally capacity increases for providers who are using ambient listening. And many organizations will go to providers and say, hey, if you'll add patients, then we'll give you ambient listening. And I'll generally recommend to never do that. Most providers are feeling burnout. And as we know, burnout increases medical errors, it increases attrition of providers, it's expensive to recruit providers. And so really for me, it's can we give you tools, can we give health systems tools that will drive ROI? And that ROI, what that generally looks like, is either using capacity that isn't being used, so like no-show algorithms and helping in operating room. I'm a reformed ED director, so left without being seen, time waiting or time to doctor. Like those are the types of things that we want our tools to enable healthcare systems to have. That's kind of number one. Number two is once you have the data of the patient, the physician, can we help you parse that data and make better decisions in the future? And so that's the other big piece that we work on is kind of the data layer, a tool that we call Fabric, where you can aggregate all the different layers of data, including FHIR data and everything, and be able to use Power BI on top of it and make your decisions more informed and better. So that's how we're doing it.
That's great. But a follow-up question for you is, are you measuring success? I mean, you talked about the clinician burnout, and that's one area that is being looked at. But beyond that, for operational efficiency, is Microsoft looking at ways to define operational efficiency in terms of what success looks like?
Yeah, so, and again, because my expertise is ambient listening, I'll go back to that. It's something that we've looked at for, I've looked at for 10 years. But with Epic, with Microsoft, we've looked at for the last 5 years in coming up with specific reports that we can show success. And so interestingly, some of the things that we've looked at have not been as successful as you would think. So time inside the EHR. You would hope to see less time in the EHR, but what you see is most providers open the EHR when they go in the room. They keep it open, and then they close it when they leave the room. And so actual time inside the EHR doesn't decrease with ambient listening. Sometimes it's pajama time. So this is at night when you hope providers are spending time with their kids, putting them to bed. That's why it's called pajama time. You want to see that decrease. And what we've seen is yes, some decrease, but not as much as we would want. And what we've found is in talking to providers want to prepare for the next day. They don't want to be blindsided walking into clinic the next day. And so they want to sit down. And where we look and we find soft success is really around that feeling of burnout and that feeling of cognitive load. And so what we'll hear is, yes, I'm still spending time in the evening preparing for the next day, but I'm not feeling stressed. I'm not sitting there dictating notes, and I'm feeling good about the next day. And then the last thing that I will say, again, that we have seen success at is increased capacity. And we see that in number of patients seen per day, and then also RVUs created per day. And we really generally see that later in the life cycle of somebody using ambient listening because it takes time for them to adopt. The other thing we note is providers who adopt to a greater extent receive a bigger benefit. So if you have a provider that uses it 10% of the time, 15% of the time, they see very little benefit. If they use it 100% of the time, they usually see a giant benefit. So that's what we see.
Great points. Ashish, question for you. I know you implemented a lot of workflow optimization in your career at UC Davis. Have there been any surprising results or lessons learned about implementing a tool when it was not taking into account workflow or current practices? Any surprises there? Because as informaticists, we know square peg round hole doesn't work. Any examples of that?
Yeah. Are you able to hear? Okay. I think actually it happens a lot more if we have an open evaluation framework before we go into it. So it's very important, I think, not only to have the projects being approved based on strategic priorities. We realize it's very important to actually put a full evaluation framework of the metrics you want to measure, because many times the way IT has been always running so fast, the go live is considered a success, right? You make it live. And it took me time to say go live is actually birth of a child. The success is if the child goes to college. So our actual effort starts afterwards. So I think that intentionality has to be there in measuring it. So when we did that, I'll give example of computer vision. Most of us are looking at computer vision technology for radiology. That's pretty common in that regard. And we looked at something which is FDA approved, got through all these cycles of committees. Ultimately, after 6-9 months of wait, the radiology chairman was so super excited, got into it, and we did a whole evaluation. Even we did the workflow analysis that the physicians are okay, it's the same screen. They are able to get flagged for a PE. It was a PE algorithm. And we found increased PE. We found 25% increased PE. And we said, that's amazing. So we signed the contract, right? Or kind of signed the contract, we were very close. And then we went back and said, physicians, would you use it? They said, no. I said, what are you talking about? Like, we did all the workflow analysis. It is FDA approved algorithm, went through all the committees, right? And we showed 25% more. And they said, oh, these PEs are so small PEs, it doesn't change the outcome. And it actually confuses us, that we now have to write, and we get more and more messages from the hospitalists that we have to put something out there. And we said, this is such a small PE. So I'm just giving that example. So we have to go all the way from process measures to outcome measures, and it should be a multi-pronged approach because we're going to be betting. And the other part is because we have a lens of bringing things on and not normally a culture of cutting down things, once we bring this on, it becomes part of the DNA forever, right? So that was a good lesson learned for us. The same lesson was in AI Scribe as well. We found such a big variation. Some physicians just take it on like this. And if you go with them as poster child, you will believe that we can force it on every single physician. But when you go deeper in the layers, and that's why you're seeing effectiveness versus efficacy data now coming. So initially, all studies were positive. Now you're seeing not so positive study on AI Scribe because not every physician gets benefited, especially if your practice is very template-driven. You already are checking like 5-10 things, like orthopedics, for lack of a better word to say that. They don't get that much efficiency many times, right? So it's also then you can cut down on license cost, right, in that regard. So there's many ways you can still optimize it, and that's what we call as the tail of transformation. That takes intentionality to look at it, and you keep on optimizing it.
Yeah, that's good stories there. But that ties perfectly into, when you say workflow and AI tools. Emily, from your standpoint, supply chain is a big portfolio of, every organization. And currently, we are having, we had the IV fluid crisis. We have had, antibiotic crises. Do you see AI fitting into that ecosystem of the supply chain in terms of helping healthcare organizations be more nimble?
Okay, I was going to say
Just need to hold it closer.
absolutely. There we go. Okay, sorry. Absolutely. I think in the last presentation, I was thinking about this with the slide with the timeline on it. I think in some ways, supply chain has been doing this for years and years and years, and it will only get more efficient. But having that sweet spot of having the supplies that you need at the time that you need them, but not having too many, sort of like the just-in-time model, AI can really help with that. The other thing I was thinking about in the supply chain world in a little bit different thought process is something that we've seen from some of our suppliers on the equipment side is using predictive analytics at their companies to help predict when things like equipment are going to go down or need maintenance rather than us being reactive to that. If you think about like MRIs, lab equipment, all of those things, the disruption that is caused when there's downtime in those pieces of equipment is huge on the provider side and on the hospital side. So we've had suppliers that have new models that will say, we now have these predictive analytics that tell us that sort of like your car maintenance light going on, but a little, more exact than that, I would say, since mine's always on. But so coming to us and saying, we want to take this down at a time that is most efficient for you, the middle of the night or whatever it is, so that we're not disrupting patient care, rescheduling patients, and losing that efficiency.
Yeah, good example there. We talked about, predictive analytics. So, Ryan, how do you think about predictive analytics when it comes to capacity management at a high volume, high paced hospital like Hennepin Healthcare, which is a level 1 trauma center, and our EDs are always overflowing there?
Yeah, I think anybody who works in a healthcare system is probably really sick of talking about capacity management, and length of stay is now a 4-letter word. I want to build off of something Ashish said, and Emily's mentioning too. I think when it comes to operationalizing AI, whether it's a predictive model or something else, I think we all have to be really, really careful about where we start. What I mean is, what are the operational levers that you're going to pull by using whatever data is presented to you with AI? And I think you gave a nice example of when that isn't the case. But we've also run into this at Hennepin Healthcare using predictive models. And I think you're going to start to see this more and more as vendors, especially EHR vendors, are pushing these predictive models out into their tools. And you've got executives and leaders across the organization saying, hey, we should use that, we should use that. Okay, what do we do with it once we get it? And that's the hard part. You've told me this forever. Informatics is technology, people, process. Technology is almost always the easy part. It's the people and process that are the really hard part to change. And so if you don't start with the change of the people and the process, the technology really becomes irrelevant. It's just another data point. And so thinking about our predictive models, we've started to incorporate some of those around capacity management, I would say with varied degrees of success at this point. We've looked at predicting estimated day of discharge either today or tomorrow. And what we've found is that, I just talked to our senior informaticist this morning, is that it's actually decreasing our accuracy because it's changing human behavior. And it's presenting the data point where that person, whether it's a clinical coordinator or a nurse, previously had that estimated date of discharge as tomorrow. Well, now it's today, and the AI model is flagging it as today, and so they change it. And so we know that model doesn't have the 100% accuracy, right? But if you combine the limited accuracy of that plus the limited accuracy of the human on top of that, we've actually seen our accuracy decrease since implementing that model. And so there's some unintended consequences of the human behavioral piece of this that we've talked a lot about around when you're presented with that information. Is there confirmation bias? Is there or is there a certain degree of de-skilling that happens over time? We don't think about these things. Someone mentioned yesterday, they can't use a map. They don't know where anything is anymore. I'm the same way. I use my phone to get home because it tells my wife what time I'm going to be there. The navigation skills, we lose those over time. And so that de-skilling, that finds its way into other things that impact our operations. And so I think it's important to be mindful of using those predictive models and what is the human element on the other end? What's the lever you want to pull? Start designing that piece first, and then the predictive model you can slide in afterwards because it's becoming more ubiquitous. It's becoming easier to build these models in pretty rapid fashion.
Yeah, that's such a valid point. So we not only have to worry about now upskilling, we talked about that a lot, labor transformation, upskilling our workforce. We also have to stop de-skilling. So that's another challenge of the AI tools in healthcare. And that's why we're having this panel. I mean, we talk a lot about the esoteric world of AI and how computer vision evolves and all of that. But this is like grassroots, boots on the ground problems that we need to tackle on a day-to-day basis. So with that, Ashish, I'll ask you the question of, you have implemented a lot of AI solutions in your own organizations. How do you make sure that the solution aligns with clinical workflows and operational goals? Because again, things can go awry very easily. How do you ensure that?
I think there's a multi-pronged strategy we did. I think one is when we did realize that we're gonna be going towards more AI automation, we first looked at our strategic roadmap, and we said these are the major gaps. And then when I started, we were getting requests from all over through email, through hallway discussions, and everywhere. So we put on a single request form. and the goal was that everything comes just through that. And some people were not comfortable filling that, so we had who are the IT intake person will we fill it on behalf of them, if you hear it. So kind of starting that culture, and that was big on the intranet posted, so people have a single request form. And within that request form, we actually put the domain names you have to check, which really were high priority items. Because one of the gaps is sometimes we can start doing things which may not be the major impact. And we may still do it successfully, and that may create an impact, but doesn't change the bottom line or the top growth for the organization. So we want to be sure we don't take any request, but we have a way to take in all requests, give feedback, and prioritize it. That was a big part of it. But when we found that, so there's a whole change management process. We started strategy, roadmap to prioritize it. Once we got the request, we have a committee. We call it an AI Strategic Advisory Committee, and a coordination group which will bubble up the top ones which are lined up in a bi-weekly meeting. So we get approvals, at least the initial business case. But one of the things is before we turn it on as a project, we actually went back to your point, Ryan, exactly who would be the person taking action, right? And we always have this three-leg thing, the clinical, operational, and the technology parts, right? So who is the clinical leader, but who is kind of in that subject domain area, and who is the operational leader that's gonna have many boots on the grounds in that regard, and from within technology also, who is the technology part. We did all that before even it goes for a cybersecurity review and everything, right? Because we want to be sure all three are there and they have capacity to actually intake and create value from it. And once all three were there, so a lot of work beforehand, right? And that's really helps success later on. And then we create one common return on health document, which will say, this is the impact we believe in the best case scenario. This is the impact we see in the worst case scenario. And that then goes from a procurement perspective or existing vendor add-on in that regard.
That's so true. And that's on the healthcare system side. But when we look at an organization like Microsoft, when you are developing tools, are you cognizant of all these barriers, thought processes, implementation considerations that are happening on the healthcare system side? Are you taking that into consideration beyond just the technology, the people and the process side of things?
It's something that we certainly try to do. And I loved Ryan's example because we often don't hear about the null hypothesis, or negative papers don't usually get published. And so it's interesting to hear that the tool, and there's I'm in Durham, North Carolina, and there's a lab locally run by Professor Duke, Dan Ariely, called the Institute for Advanced Hindsight, and he talks about how humans are just rationally irrational, and how it's so difficult to predict what a human will actually do with technology. And so when we think about it at Microsoft, we dig in with partners, we go on site, we try to understand the system, we have a ton of clinicians that work at Microsoft, and still, it's not going to be perfect when we deliver it. And one thing we try to do is we try to move quickly and deliver to market as quickly as possible. And when something goes generally available, I would still say it's still not gone to college. It's just born, and it still needs to be tweaked and enhanced. And so that is absolutely the process that we kind of go through to try to bring things to market that are useful.
Thank you. So Emily, question for you. If you had a crystal ball, and I know a lot of your time is spent in driving operational efficiency, outcomes, resource utilization, that bottom line, are there any next big trends in AI that you see to drive these outcomes?
There are so many, and I think there's so many ways that AI will help us be more effective and provide higher quality care in the future. I guess I'll just, going back to the operational efficiency, it is so hard. Staffing alone is so hard in an inpatient setting and in an emergency department, maybe even more so. Mostly because humans are humans, and what did you say? Irrationally irrational. And including all of the things that go along with patient care, like comorbidities, et cetera, but that doesn't even get into the social determinants of health that we see at Regions and that you guys, not you anymore, but you see at Hennepin. And having a model, a predictive model that includes all of those things that help us to use our resources the most effectively would be amazing. The other thing that I was just thinking about that you were talking about a little bit is in the emergency department. So between Hennepin and Regions, those are the two busiest emergency departments in Minnesota by a long shot. And we are full all the time, and I know you guys are full all the time too. And one of the things that we are really focused on that I think AI, Microsoft could really help us with is we try really hard to get the patient to the right level of care that they need at the right time. And basically, we don't want you in the emergency room if you don't need to be there, and you do not want to be there if you don't need to be there. So are there tools in the future? If I had a crystal ball, I would love a tool that could predict from somebody walking in the door, this person doesn't necessarily need to be here. They would be better served at an urgent care, or let's get them a primary care appointment or a specialty care appointment and make more capacity for us, but also help them to get where they need to go.
Ashish, you want to add something?
Just to respond to that, I think sometimes the low-tech solution is fine as well. We had exactly a similar problem in UC Davis Health, and we had a big operational center for excellence, and one of the key things we did is we partnered with, it's Dispatch Health now, it's merged, to set up a virtual urgent care center, and they directly do the payers contract. So we just had a person in between, which will take any intake call for any person who's going to go to ED. And based on the predetermined logic, it was able to say, hey, you don't need to come in, but you may still need something, so we'll have the team see you in your home. And we just published, actually, New England Journal of Medicine, the impact of that and how many ED visits we stopped. Like, we were able to do that. So I think that's amazing, because then that's perfect from a care transformation. And not just from not just technology part, but we sometimes don't have capacity outside ED to refer to, and that's what we built that helped us.
So to wrap things up here before we open it up for questions from the audience, I would like all of you to answer the question of, if healthcare systems are looking to implement or introduce AI, what is the one piece of advice you would give them? Let's start with Emily.
I would say to really think about the problem you're trying to solve. And there's so many awesome AI tools, like I think about the concept of a smart hospital and digital whiteboards and all these really cool, sexy things that are like, oh my gosh, that's awesome, we want that, we want that. But when I think about the actual core challenges that we have, capacity management, length of stay, right place at the right time of care, expense, inflation expense, supply expense that are totally out of control, really thinking about what is the core problem that we're trying to solve, and then looking for what can help solve that problem, and then starting small and very well defining what the success metrics look like. And not until you have achieved those success metrics do you spread the solution.
Thank you. Jared?
So first, you define the problem. Second, you come up with the implementation plan, and it needs to be way better than you think it needs to be. And that's because of the people part of it. People, physicians, nurses, everybody is so busy. And so if you're going to ask them to train on a new technology, it's most likely not going to go well. And so you have to come up with the best process for implementation. And I think that a good solution will fail with a poor implementation.
Great. Ryan?
Well, I love both of those. I would have said both of those, but I guess number 3 on my list then is, how are you going to monitor these tools? This is not like a best practice alert or some clinical decision support tool that is static. And we all know that we are terrible at monitoring those because we have committees to take them out of the system because they've all just been bloated over time. This is different. This is a dynamic model in many cases that will change, and there'll be model drift, and it will change the way that humans behave. And so if the healthcare system isn't equipped with a group of people and expertise to monitor that, I think the consequences can become really significant. And there's hundreds of examples of this that have been published. And so I think thinking about this from the lens of a healthcare system, how will you monitor these tools after implementation? I think that's going to be as important as the process leading to implementation.
I can't beat this, so I'll try to summarize in some way. I believe, irrespective, we all believe we will need advanced technologies and AI to really, we need it. We needed it yesterday. And I think we need to build capacity within our organization, the capability within our organization, because it's not just the vendor technology, it's actually us for transformation. So we need to build capacity for finding the right problems, the highest priorities that need to be solved, prioritizing it, but then building capability to digest it, to basically create value, then build it, and then ability to actually monitor it and deprecate if it's not needed, right? So that onus is on us to be able to really use AI in the right manner to transform us. And that there's never too late. That's the one thing which we should start doing and learning from others.
And it all comes down to then the human.
Yes.
I read a great quote yesterday where intelligence can become artificial, but stupidity is still original. so if you have these tools, but you're not thinking the right way in terms of operationalizing and driving efficiency, of course you're going to fail. So with that, let's open it up to the audience for questions. Oh, we have some hands up.
Thanks. Let's see, the traditional, is it on? So thanks for everything. It was really good to hear about, on the ground issues. I was wondering, we've talked a lot in the last day and a half about, things not always going right, but there's often not the space for that in healthcare. Like the goal is, perfection. And I was wondering how, and this could be directed to any of you, provide that thoughtful space for smart failure so that you can fail, learn, and move ahead. And what role you think that's going to need to play in the next, few years as this technology continues to evolve.
Who wants to take a stab at it? Ashish, you want to take a stab at it?
Stupid way, so I can answer your question for smart failure too. My evolution about this fail fast, coming from East Coast into West Coast, I always thought, hey, this is great, fail fast. There's no tolerance to fail fast. People will say, why did you even pick this project if you know it's going to be failed like that, right? So I think if you deconstruct it, few learnings that we had done, I'll give a very specific example, which actually I still remember every single day to remind me. If we do a lot of pre-work, that decreases the chances of full failure. If we keep on doing the work of analyzing it, there's so many pivots we can do to convert that failure to actually a semi-successful success. So in a way, instead of stopping saying it's a failure, it's learning from it like a PDSA cycle, we're learning it to fine-tune it, right? Not a model, but ourselves. And I'll give you an example which would have completely changed the trajectory of my career and what we did at Mount Sinai. If we would have just stopped saying it's a failure, we would never gone far. When we built this app prescribing platform for the first time, we did not know what the acceptance. We said if 100 physicians prescribe it, in the next month, that's a success. Because the first time we were asking physicians to prescribe anything that is not medicine or procedure, it's actually an app. We had an amazing intern who's actually now medical director for a Mayo Clinic platform, Sonia, just superstar. We couldn't have got a better person than her. She went, and we went to 4 different departments unit. In 3 or 6 weeks trial, 3 weeks, not a single app got prescribed. Not a single app. I said, oh my God, like 2 years of work, completely failure. And we were on a pizza kind of together, just brainstorming. If we had stopped there, the end of that success, we ended up touching 30 million lives after that. What we pivoted from, maybe we don't have to have physicians prescribe it. we can just have a front office prescribe if a patient is eligible. And instead of giving an asthma app, maybe we prescribe MyChart app. Game changer. Any patient that came to the front office check-in, they said, oh, do you have MyChart app? No. They prescribed it right there. Next 3 weeks, we prescribed 2,000 patients. 92% acceptance rate, right? That ended up being 30 million prescriptions. So I think sometimes it's very important to have, and instead of judging, it's very tough for humans to do. We have this thing of yes or no as a no gray zone in terms of analyzing technology. Truth is many times in the middle, because if it was failure, you would not actually even bring it inside, right? So there's some success in AI Scribe, right? Happened. So what is our thing which is different? Who is using it? How they are using it? Can we change that part to tweak it? Is what I would recommend in that regard. And if after tweaking, you're just not able to make sense of it, it's still failing, then you need to deprecate it at some stage. But keep the lessons learned, because that will be useful, because the domain name which you started to conquer already was high prioritization. So you still learned something for the new initiative that you're going to bring into that area.
Thank you. Emily, you want to add something? Here, you can have this.
Okay. I was just thinking about, medical errors happen in hospitals all the time and in healthcare all the time. And one of the things that we do that you mentioned a little bit is a root cause analysis when bad things happen, so that we can try not to let them happen again. And I think that the most important thing that an organization can have to aid in what you're saying is a good, healthy culture of speaking up. And all of us that lead at hospitals or in any level in healthcare, that's our responsibility to be accepting of speaking up and accepting, knowing that problems happen and focusing on being better because of them. And I think that you're bringing up a really important point.
Yeah, they say culture eats strategy for lunch. So yes, culture is very important. We have one question in the back there.
Today I've heard a lot about improving patient care and ways to do that. And the question that comes to my mind is, does a patient have a big enough lever on the organization to really affect change? And this question came to me by thinking about a podcast I listened to recently about Epic Systems. And it was a really good podcast. It was like a 3-hour podcast. Anyways, they stated that one of the secrets to their market dominant position has been to focus on billing. And they have sold a lot of their systems and found it to be really very receptive to that. So, kind of my question is, does the patient have a big enough lever, or is it something like the health insurance that has a much bigger lever that is able to make change and not focus on patient care?
Yeah, and that's a great question, is patient-centeredness of all our AI technology. So Ryan, do you want to take a stab at that?
Yeah, I can take a stab at that. I think you're highlighting one of the biggest challenges in health IT in general, is that the patient experience often isn't incorporated into our measures of success. And it's sometimes hard to get that perspective into a room of IT leaders or operational leaders, but it's paramount, right? It is the reason behind what we do. One of the things that I've been thinking about the last couple of days is there was a study published several months ago looking at AI and the in-basket and drafting these responses. So generative AI drafting in-basket responses back to patients. And the study was looking at empathy, and the empathy scores of the AI-generated in-basket messages were like 40% higher than the physician messages, right? So everyone was like, oh my gosh, this is so great. And then the reality is, if you strip that away and you start looking at the messages themselves, like the actual messages, the empathy was conveyed by the length of the message, right? It wasn't necessarily that the content was better or that it was actually more empathetic, but it was conveyed as, this person's investing a lot of time into me, because the patient wasn't necessarily sure it was coming from AI or a physician. I worry about that empathy score over time having diminishing returns and the patient experience not being the same because they're going to expect that these messages are coming from a AI chatbot. And how does that change their perception of the engagement with the healthcare system? And so I think as clinicians, as hospital and healthcare leaders, we have to be very cognizant of once this becomes more commonplace and the novelty and the shine wears off a little bit, how does that perception change, right? So someone should redo that empathy study in 2 years. And just because it's a long message, does the patient still feel the same way that it's empathetic? Or are they like, oh, great, that was a nice AI-generated message, but I'd like to hear something more substantive from my healthcare team. And so I think that's a really important call out and something all of us can't lose sight of is what is the patient perspective on all of this and make sure that we keep that, keep a good pulse on that.
Yeah. Well, wait till we introduce more bots because then the bots need to be empathic to each other. And let's see where that gets us.
Exactly.
We have time for one more question. Jaydeep has a question right here. That's fine.
Since we have all doctors on the stage, I have to ask this question. Especially, Ryan, you said about, we talked about upskilling, reskilling, and de-skilling. So the question is, I think yesterday in one of the panels, there was a metaphor of as cars became more sophisticated, the drivers were able to get rid of something. So, now you don't have to do clutch and gear, accelerator integration, and now we have come to the, you have to unlearn how to pump the brakes because of ABS systems. So over a period of time, people discovered there are certain skills that because you didn't have technology, you had to do it, but those are not essential skills. So the question is that whenever you're talking about reskilling, you have to create some space, right, in your efforts, mind, whatever. So the question is there a systematic effort in the medical community, starting from medical schools, to examine all the skills and say, which ones should we forget? In fact, in the driver domain nowadays, if you're taking a Waymo, you don't need to even know how to drive. You perfectly get from one point to another point. So the thing is that what is there a systematic effort and what does that need to be? In fact, I'd actually to see that, the very last thing you gave was a great example of, so now the question might be with this AI versus human response. Maybe a doctor's response becomes a prompt to an AI system to make it more empathetic. So the content is coming from the doctor, and therefore it has substance, but it's a prompt that adds an empathy layer to the final response.
Thoughts? That's very true, and I'll take a stab at this myself, Jaydeep. So we are actually working on that, where you train what we call augmented response technology to sort of train itself. The problem is personas. Every doctor has their own persona and their own style. I had a patient actually tell me, what happened, doc? Are you okay? Because I used to write one-word responses to my patient messages, and now there's a paragraph there. And we have taken the stand of full transparency. So my response does say this response was generated using artificial intelligence. So the patient themselves sort of knew something is going on here. But the persona of the doctor, some doctors, write long responses, some don't, and the technology needs to evolve in a manner that actually adopts the persona of that individual provider. And that's the tricky part about it. But I work with AAMC, which is the Association of American Medical Colleges. So to answer your first question, yes, there is work being done. However, what I see as the problem there is it is an add-on. So what they are training is, doctors need to be trained around AI, and doctors need to be trained around decision support, self-service analytics. So, these are things, but they are adding this to the curriculum in addition to what traditionally we were teaching medical students and residents. And I don't think that's sustainable. So I think your point is well taken, where you need to take away something and then supplement it with the newer technology tools. Anyone else?
I totally agree. I think this is one of the struggles of medical education in general, is that the field is advancing so rapidly and there's new aspects of care delivery let alone all the changes to pathology and diagnostics that are coming along the way. Something has to give, right? And we haven't created that space yet. I think the thing Jared said yesterday that I can't stop thinking about is that story about how litigation is driving AI adoption because people are fearful of not using these tools because they don't want to get penalized or in trouble for it. We have to be so mindful of that. I've thought about that nonstop since you said it, and that this is where the work at the AAMC, the work through ACGME has to be first, right? We have to lead with good policy, good changes to curriculum. Otherwise, that aspect seeps in, and that takes you down a path you don't want to go down, right? And I think that is what I'm going to take away from this is we really have to build these curriculums to take advantage of the fact that otherwise there's other forces that are going to force their way in, and we don't want that.
And it's not just medical education. This applies to every workforce in the hospital setting. Nurses, EVS workers, transport people, nutrition workers, everyone needs to have this sort of educational background in some manner. So it's not just restricted to doctors alone. Well, with that, I want to thank my panelists for sticking with us till the end of this session. And we are running a little behind, but everyone else in the audience is waiting to network and lunch. So let's conclude this. We have a few closing remarks, and then we will conclude the conference. So thank you, everyone.